everyone. My name is Gurwant, and I see many people have left, so we have thinned out audience by now. So thank you for those who have stayed for this presentation. So I want to say we are starting at 3:45, so we'll take another extra 15 minutes till 4:15, right, Dr. Farouk? Okay. A topic is the social determinants of health in people with kidney disease. And we'll be talking about what is the definition and what are the factors that impact our health and what are the factors that contribute to these and what can we do about them. What is the definition? The conditions and the environments in which people live, learn, work, play, worship, and age that affect a wide range of health, their functionality, and the quality of life outcomes. I want all of the people who are present in this room take 30 seconds and think about what have been your life events that have led you to attain the education, the titles, the things that you're able to do, and that had made you be capable of sitting in this room today to be part of this healthcare team. What have been your life events, and what have you been your obstacles that you might have to overcome to be here in this day? So we are talking this in context of CKD. More than 1 in 7 people in U.S. have chronic kidney disease. That's about 15% of U.S. population and about 37 million people. So that's a lot of people that we take care of. And the facts are that 9 out of 10 people, they don't even know they have CKD. How many in this room know their creatinine and the GFR? I know mine is 0.7, so that's pretty good. So, and 2 in 5 adults who have severe CKD or advanced CKD, they don't even know they have CKD. So those are pretty significant factors that we need to talk about. So what are the social determinants of health? Basically, what has made us attain the education that we have today, and what is our social or community context? What is the economy that we live in? And what does our neighborhood look like? Or what kind of healthcare or clinics or hospitals we have access to? So social determinants of health, they are powerful predictors of mortality and morbidity in general population, as well as in the people with CKD and end-stage chronic disease. And they also determine their adherence and ability to receive medical advice and able to follow through those recommendations. So we can't move forward on this talk without talking about race and racism. So race is a social construct based on some physical characteristics. We all as species share 99.9% of our DNA, so it is not a biological construct, it's a social construct. What is racism? The false belief in the superiority of one group of people based on race that advantages one group of people, whereas unfairly disadvantages another group of people and communities, and it hinders the strength of the community and wastes the human resources. I was born and brought up in India. We don't have race, but we have something called casteism, where people are differentiated based on high and low caste. So even though I'm not born here, I haven't experienced all the things that many people might have experienced in their lifetime here, but I know the social construct that casteism has played in Asian countries. So racism is a social construct, not biological, and race is not a risk factor for CKD. It's the racism. So I'm going to repeat. Race is not a risk factor. It's the racism. And in short, racism kills, whether it's through force, through deprivation, through social discrimination. And it's the fundamental cause of the disease and what leads to healthcare inequalities or inequities. So this is what equality looks like. We give the same kind of stepping stool to everybody, but this is what they really need. Maybe the little kiddo needs 2 to get over the fence. So that is equity. But then why do they even need the stools? Why don't they have equal access as everybody else has? So health equity in the health environment that we work in is not simply a moral imperative. It's a necessity. And health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs, fair pay, quality education, housing, safe environment, and healthcare. So why are we even talking about that? What is the impact? Impact is it leads to poor health outcomes. So if we think about kidney disease, the diabetes and hypertension are the leading cause of kidney disease and people of color are disproportionately presented in people with kidney disease. If we look at African American, they make up to 13% of US population, but they account for 35% of Americans with kidney disease. And they're 3 times more likely to have kidney disease than their white counterparts. Look at Hispanic Americans. Population have 14% of kidney disease. And for every 3 non-Hispanics, 4 Hispanics have kidney failure. About 1.6 times more likely to have kidney disease. Look at Native Americans. They're about 1.2 times more likely to have kidney disease than their white counterparts. And these disparities became more obvious during the COVID pandemic. African Americans had the highest mortality rate per 100,000 population, 92.3. Next were Hispanics, about 74.3. Then white Americans, 45.2. And the lowest among Asian community, about 34.5%. So what are the factors that really lead to these differences? Unstable housing, behaviors in healthcare like safety and mistrust, environment pollution, food insecurity, economic instability, and education. So talking about housing is a critical contributor to kidney disease. Not only housing, it's the unstable housing. Kidney disease disproportionately affects individuals of lower socioeconomic status, and 34% of the people with newly diagnosed kidney failure, 1 out of 5 have households below federal poverty line. And it's the result of decades of racist housing policies and lending policies. Homelessness face higher rate of mortality, higher use of acute care services, higher rate of suicide, and unintentional injuries, infectious diseases, and mental health problems. And people with CKD experiencing homelessness are 30% more likely to die than people with CKD who have stable housing. And how many of us, when we take the social history, even bother to ask our patients if they have stable housing? And it's not the patients that they're going to come up themselves, because we don't like to talk about things that we don't have access to. So historic racist and social policies like redlining intentionally situated communities of color around the hazardous industry areas. This is a map of 1936 Harrisburg area. The red spots represent communities of color around the black areas of industrial pollution. So these are 3 different pictures of houses. So we can all ask ourselves, what kind of house do we have access to at the moment? Which one of them really represent us or our friends or our neighbors? And which one do we wish to have if we don't have the one that we wanted? So unstable housing, especially in kidney disease patients, lead to higher mortality. And once someone has a kidney disease or they are on dialysis, that hinders their ability to work full time or continue to keep their jobs that they had before diagnosis of CKD, which would in turn lead to even more unstable housing. So it's a vicious cycle that keeps on going, and we might not be aware at all. So stable housing is a basic human right and is tightly connected to the health and outcomes among people with kidney disease. So if someone is facing housing insecurity, which is defined as having high housing rent or overcrowded or unsafe living conditions, and think about if they have unstable housing, how they are able to store their medications, or let's say if they're transplant, the complex medications. And we talked a lot about home modalities, but how they're going to have a home modality if they don't have a stable home? So we need to inquire into that if they have a separate room, and they might be living in spaces where they have shared restrooms. So how they're going to have setup of home modalities at home. And they're 3% more likely to have albuminuria, means proteins in the urine, and 60% more likely to postpone the needed care that has been recommended. And if they have unstable housing, they might not have refrigerated. How are they going to follow through the dietary recommendations that every time they keep hearing when they come to the clinic? And because of lack of stable housing, they might lose their benefits because of not having a permanent and consistent address. And they also might lose their transportation facility benefits because of the changing address all the time. So we can't really blame someone who misses the dialysis appointments if we haven't taken the time to acquire what has made them not show up on that day for dialysis. So poverty, this is a picture from a YouTube documentary, Poverty in America. So this is an article from Philadelphia correlating poverty and kidney disease. The one in the blue represents map of Philadelphia, and darker the color, darker it represents the concentration of poverty, and it is very well correlated to the red dots on the left, which represent prevalence of CKD. And so in this study, they found that higher CKD prevalence were related to neighborhoods that have lower walking distance or walkability, and lower percentage of high school graduates, lower median household income, or higher percentage of residents living below the federal poverty line, and a higher percentage of non-Hispanic Black residents, and higher violent crime rates, and lower neighborhood social capital. So poverty is very well related to the incidence and prevalence of CKD. Next, food insecurity. Again, how many times we take time to ask patients if they had a meal, or how many times they were not able to afford a meal in the last week. So trends in food insecurity, this is a map showing among patients with CKD stage 1 and stage 2. 1 in 4. So 1 in 4 patients with the CKD is food insecure as per CDC data on March 2020. And I'm going to say I usually was not aware of this data. And I was like, wow, I have never taken time to really ask about it. And I don't know if there's a comfortable zone that we could ask this directly till we have that physician-patient relationship where we are open and honest to each other talking about things. So food insecurity, it's the perception that food is not available. About 11% of households in the US, means 1 in 9 households did not have enough food each day. Associated with an unhealthy diet, which increases the risk of diabetes, hypertension, which are the major leading causes of CKD. So 3 different pictures, what do they represent? So do we have a household income that can afford us fresh fruits and vegetables? And do we have means to get to the grocery store and buy that and bring it home safely? Do we have places to store that food? And fast food, maybe we don't have access to fresh food and we are mainly dependent on the fast food. Or the third picture, we don't have enough food at all. There is just not much food available to eat. Next are the environmental factors we live in. So the article says we all must join in an effort to dismantle environmental racism. What it means is the air pollution, that percentage of air fine particulate matter, more exposure to that is associated with increased risk of chronic kidney disease and its progression to end-stage kidney disease. What is pollution disadvantage? Black and Hispanic communities are more exposed, about 50 to 60% than their white counterparts. What is pollution inequity? It's the amount of exposure to these air pollutants as compared to the pollution created by use and services by you versus the other community. This pollution inequity exists that Black and Hispanic communities are more exposed by the use of goods and services by white communities. Clean Air Act, it has worked to improve the overall strength of air cleanliness, but it has mainly improved the air pollution among the white communities. So what we need to do, the data that looks between the surveillance data that monitors these pollution levels must be linked to the research that is looking into the health of these patient population. So lead. So lead, living in the cities with higher concentration of lead in the drinking water has led to lower hemoglobin, means more anemia, and more use of medications to improve anemia. And this was associated with lead levels that are not even considered actionable by the environmental protection agencies. Adult Black patients with ESRD are more exposed to higher level of lead in public drinking water than their white counterparts, and it leads to more severe form of kidney disease. And half-life of lead is long because it's stored in the bones. So even childhood exposure, differences in childhood exposure would continue to have their health inequity presentations in adult life as well. So these are the few different forms of environment. And again, kind of looking a little bit of self-reflection that what kind of water source do we have from picture 1 to 3, and what kind of schools, libraries, healthcare institutions that we have access to, or what kind of education that we have access to that would impact how we consider our health factors and how we are able to go through, follow through the recommendations. So special population among incarcerated. How many of you have taken care of somebody who was incarcerated, brought by policemen to the clinic and in shackles? And how do we kind of make that environment comfortable where person doesn't feel like a prisoner? We treat them as a patient and as a human. So kidney disease among people who are incarcerated, the risk factors, the population in the prisons and jails predominantly constitute non-white communities, and which are to begin with at higher risk of developing multiple chronic conditions. Hispanic and Black men make up to 3 times and 6 times of sentenced population than white counterparts. And communities of lower socioeconomic status are represent more of this population. And there are a few numbers written here that individuals aged 55 and above are likely to increase by 80%. They have increased by 80% between 2000 to 2009. And also people above 65 have increased by almost more than 280%. And it's estimated that by 2030, people above age 55 will constitute about 1/3 of the prison population. And also other risk factors, obesity. Black men have more than white, and females have more obesity than men. And all the other factors that contribute to CKD are more in this prisoner population than in the general population. So CKD care, there's very limited CKD care that they have available. Even the basic things, checking your hemoglobin or creatinine or your blood glucose, this could take days before the appointments are made or before somebody is seen, and something could be done about that. About dialysis and transplant, there's almost no data on national level, and there's no national regulation. We don't know how much dialysis access they have, how many people, while they're going through the criminal system, they have access to transplant evaluation, or how many have actually gotten a kidney transplant. And the post-prison life, it's associated with stigma that might inhibit them from getting good health care. And also higher mortality in the first 2 weeks after they're released from the prison, mainly from drug overdose. And second most common cause is the cardiovascular disease, which is very well directly linked to the kidney disease. Next is education. So education, association of education attainment with incidence of CKD in young adults. So these 3 tiers represent if we go from high school, college, and then post-college education, the incidence decreases as we have more academic education. And the graphs on the right represent rate of decline of kidney function over time, which is less among people who have college or higher degrees than just with high school. So this made me think that, okay, the solution seems to be simple. We improve education and we lower the poverty. That would improve the kidney health and the outcomes and other chronic conditions like diabetes and hypertension. So this is, these are the graphs from, I have a pointer, yes. So these are the graphs from Business Insider. So this basically represents that a white person and a Black person, if they both have post-college education, a white household would make more than 3 times as wealth as a Black household with the same post-college degree. The lowest tier represent that a Black household with a college education have less wealth than a white family who did not even complete high school. So where the equity and equality lies, if someone has worked hard enough to get the same level of education, then why they don't have the same amount of wealth and same access to resources? I don't think the answer is simple, but this gives us something to think about when we're dealing with our patients. And over time, from 2000 to 2020, the income and wealth of white communities continue to grow up, whereas of Black communities and Hispanics remain unchanged. Then is mistrust. I heard a comment made earlier about trust versus mistrust among communities of color towards the healthcare system. So if any mistrust a Black patient may harbor toward U.S. healthcare system is the result of this never-ending mistreatment, is not the cause of it. We cannot blame a person to not be able to trust a healthcare system when the infrastructure itself is set up in a way that leads to inequalities and unequal access to resources. So people who repeatedly face systemic racism, discrimination, social isolation, demoralization, mental health problems, and violence may not view medical facilities as safe. So we have to be careful and watchful about the words we use, the body language we show when we are interacting with the patients who may give us some signs about their mistrust. So we need to take a step back and find out why or what has led to that belief. So what can we do about all these situations? Sorry. So acknowledging that racial and ethical inequities are neither normal and they are not acceptable. Discovery and documentation is important, but historically data has shown it hasn't resulted in any improvement. So call for action for proposing strategies that will make a difference and call upon funding. We just don't need ideas, we need the funding to support those ideas. And also examining how the CMS makes policies and how that would impact future health. Promoting policies that affect the physical environment that we live in, that we grow, we work, we play. Race-free approaches to GFR, that we had a good lecture by Dr. Brett today, need to explicitly acknowledge that race is a social construct, and anti-racist reimbursement policies in end-stage kidney disease, that we cannot ding the dialysis units who basically serve communities of color if they are not reaching certain level of productivity. Instead, they need more support versus taking away any incentive from those dialysis units. So goal is elimination of the disparities. Education and screening are important. Spending more time on housing research so we can promote home modalities, and think before we say someone is non-compliant. Instead, take a step back and probe about housing and social challenges and involve our wonderful colleagues in social work. Oops. So equity matters. The only way to achieve equity and eliminate disparity is identifying them, confronting them, and overcoming systemic racism in the healthcare, science, and kidney medicine. And we need diversity, equity, and inclusion, and anti-racist initiatives for physicians and medical research and leadership. One important thing that I felt isn't under my control in this whole spectrum is the rigorous standards for publishing on racial health inequities. As a researcher, if define race during the experimental design and specify the reason why you needed to use the race in your experiment. Never offer genetic interpretation of race because the science does not support that. And when we submit that article or manuscript or research work to the journals, they should have the moral obligation to reject articles that use the race, but they haven't examined the race rigorously with all the factors that are involved. And as a reviewer, when we review those papers, if they could be accepted or we need some changes in that, be critical of the work. That biological race, that like we can provide a genetic basis for that, and review the citations. What kind of work they have based their work upon, and is that sound, or is it socially sound, or is it medically sound? So similarly, ASN, American Society of Nephrology, evaluates the policies based on what's in favor of the patients with kidney disease, the communities, the leaders, the physicians, and that's what ASN tries to do. Oops, sorry. So as a physician, we also have a role in identifying the social determinants of health. When I write a note for my clinic patient or inpatient, to me, most important part of the history taking is their social construct, like who drove them to the clinic, or who do they live with, or where do they go for groceries, or can they follow a dietary restriction or so. So there are a lot of coding system in the coding entries that are available that exactly talks about if they have any limitation or challenges towards education or employment, or if they live alone or they don't have access to good resources. So be mindful of that, be aware of that, and try to put that in your notes so that other people who are reading your notes or reviewing the chart can also be aware and and an action could be taken. So this is my last slide. So the goal is move from inequality to equality to equity and to justice. And I'll leave these slides for 30 seconds for interpretation. The first slide, it shows that tree is actually bent towards one group of people. And if we give them equal ladders, that's still not gonna clear the obstacles that both groups have. In the equity group, one maybe needing a bigger ladder or taller ladder to attain the same health outcomes. But I think justice basically correcting the system where we need to not have that tree bent towards one group of people to have them more fruits than the others. Thank you so much. And this is our wonderful group in our Penn State Nephrology. We advertise ourselves as a happy group that works hard and take care of our people with different range of kidney diseases. Thank you so much.
I, of course, have a question. You knew I was going to, right? So do you think that when, I love coding. I used to work as a nurse coder. So if we were to really examine those Z codes, those non-compliant codes, how do we use those? Do you just, are we really give thought to when we say that somebody's non-compliant, do we look behind that about, we're not saying that they're not, but are we looking at why they're not? I mean, are they not compliant with taking their insulin because they're sharing their insulin with their son, who they can't afford all the insulin they need? So could we, at some point it might be interesting to look at Z codes, those non-compliant codes, not compliant with dialysis, not compliant with whatever their regimen is, and then correlate it with women, with age and gender and race and socioeconomic status. And we might start to see a trend that what we tend to see and we call non-compliance really is related to not inequity, not having access. I'm just curious about whether you think there might be some correlation there.
So I think that's so basically the question is, can we relate those non-compliance codes with any certain factors? So I did not look into that for the sake of this presentation, and I don't know how much research has been done, but this is from, I think, 2020 ICD codes that were updated, and we have all the different options available to code. From my perspective, the idea of, I don't like to call somebody non-compliant or unless I have taken time to kind of really figure out what's going on, or is there something I can do about it? Because I might prescribe a medication that's evidence-based, it's proven to have wonderful outcomes. If they don't have the means or right insurance or right means to store that medication, how I'm benefiting that patient, right? So I think so I think it could be a wonderful project as well, looking within our system to kind of see how those are related to different age groups and gender. Yeah, thank you for the comment that.